Hello coders! Today we're picking up with Medicine Part 2. We're starting on page 626 under the Cardiovascular Services. The first thing you're going to notice is all of these codes are now out of numeric sequence. This happened a few years ago. They moved all of these codes to a slightly different section. So what I like to do for large sections like this, I write the page. So you'll find these codes starting on page 629. So we'll talk about those in just a few minutes. Then we get to our other therapeutic services. This is where we find our CPR and our temporary transcutaneous pacing. So again, these are things that are going to happen in ambulances, doctor's offices, emergency departments, etc. We also have the cardioversion, electrical conversion external. These are the paddles. So again, depending on what the reason for the person collapsing, we might use the paddles instead of CPR, or we might use both at the same time. We have internal, that is when the chest is actually open. So that's something that's going to be done during major procedures. This is not something 92961 that's going to be done, in an ambulance per se. As we continue going down, we have some cardio assist methods that we may use, and then we have another series of codes, which again, these start on page 630. Then we start seeing a few percutaneous procedures. Remember, cardiovascular is in three sections. It's in surgery, it's in radiology, it's in medicine. Most of these procedures that we're going to see in medicine are going to be percutaneous and what we consider minimally invasive, going into a vessel instead of slicing and dicing the patient. So this is going in and opening up the actual valve itself and then doing a surgical repair. Remember, plasty is a surgical repair. So again, which valve? The aortic, the mitral, the pulmonary, etc. Then we get to our coronary therapeutic services and procedures. So again, these are the codes that start on page 626, but are actually sequenced on page 629. So it tells us codes 92920 to 92944 describe percutaneous revascularization services performed for occlusive disease of the coronary vessels. These are the major coronary arteries, the coronary artery branches, or coronary artery bypass grafts. So remember, the coronary vessels are the arteries and veins, specifically more like the arteries, that are going to feed the heart muscle its blood supply. And so these are what tends to become occluded, can be filled with fatty plaque, cholesterol. You can get a blood buildup that can basically make those vessels become much shortened in the blood flow that goes through, and then we're looking at possible myocardial infarctions. So these can be done before somebody has a myocardial infarction if caught in time. A lot of times these are done afterwards because the myocardial infarction happened because one of these coronary vessels was occluded. We can also do this for the bypass graft. So again, if someone has had a bypass graft, the bypass graft itself can also become filled with a fatty plaque substance. Now, these, what we call PCIs, percutaneous coronary intervention codes, are built on progressive hierarchies with more intensive services inclusive of less intensive services. So again, if you are going to code for these, you need to know what is always included in the code that you're going to use. Now, these PCI codes all include the work of accessing and selective catheterizing the vessel, traversing the lesion, radiological supervision and interpretation directly related to the interventions performed, closure of the arteriotomy when performed through the access sheath, and imaging performed to document completion of the intervention in addition to the interventions performed. So again, what's included? Deciding where they're going to puncture into the body, getting into the body, getting to the area, which is traversing the lesion, all the radiology associated with it, closing the arteriotomy, the actual puncture that we made to get into the body, and then doing imaging to make sure it works. It also goes on. These codes include, so more inclusion here, angioplasty, which can include balloon, cutting balloon, wired balloon, or cryoplasty, atherectomy, which can be directional, rotational, or laser, and stenting, which can be balloon expandable, self-expanding, bare metal, drug-eluting, or covered. Okay, so again, When we're talking about cardiac surgery, we talk about a lot of these different types of procedures. But again, most of cardiac surgery is more slicing and dicing, although it's getting to be more of these percutaneous procedures. Because again, as we talked about in our cardiology 1, 2, and 3, we're trying to get as small as possible. So we're seeing more and more percutaneous procedures because, again, if we can go into a small incision, a small puncture into an artery or a vein instead of slicing and dicing open the chest cavity or the neck, then again, it means less time for the patient to recover. And again, it's easier to treat because we know that the complications are less. Now, for those of you who have already done the radiology section and watched the cardiovascular surgery, you'll know that the next set of guidelines are the same exact as the radiation guidelines. When can we code for a diagnostic angiography and when can we not? So the biggest thing here is that the diagnostic coronary angiography codes 93454 to 93461 and the injection procedures 93563 to 93564 should not be used with the percutaneous coronary revascularization services 92920 and 92944. And again, it's because this is included in the 92920 to 92944. So again, what is included? However, like all of our other angiography and venography guidelines, we can code a diagnostic angiography at the same time if one of these circumstances is true. Either there is no prior catheter-based angiography study, so we want to see what's happening before we get in, or the patient's condition has changed, or there's inadequate visualization of the anatomy and pathology. Again, it could be a test from 20 years ago, or there's been a clinical change during the procedure. So those are reasons when we can use the diagnostic coronary angiography codes. So we want to be careful. Again, when we're coding, we have to make sure what else is going on and what is included in the codes and what is the history of the patient. So it's going to be important if you end up working with surgeons who perform these surgeries that they are clear with you whether or not the patient has had an angiography before. And so again, that could be in a note, that could be in the surgical report itself, but we need to have this information documented so we know which codes to choose. Now, as we go through the rest of these guidelines, the biggest thing we have to remember is we have coronary artery modifiers. Now, you'll find these modifiers in the front cover of your book. You will also find them in your HCPCS book because they are HCPCS modifiers. So we have 5 main coronary arteries that we actually end up using modifiers for. Okay, and so again, they tell us the major coronary arteries are the left main, which is LM, the left anterior descending, which is LD, the left circumflex, which is LC, the right circumflex, which is RC, and the ramus intermedius, which is the RI. Okay, so again, if we're doing any of these, we better have that modifier with it to specify to the insurance company which one of these major arteries did we perform the PCI in. Now again, all PCI procedures performed in all segments, proximal, middle, and distal of a single major coronary artery through the native coronary circulation are reported with one code, meaning, again, we use one puncture to get to that area. When one segment of a major coronary artery is treated through the native circulation and treatment of another segment of the same artery requires access through a coronary artery bypass graft, the intervention through the bypass graft is reported separately. So again, how are we getting there? So remember, the word native comes up both on the diagnostic and the procedural side. So when people are having the occlusion of a native artery, it means it's one of these 5 arteries they were born with. But remember, on the diagnostic side, and it becomes important here, if they have a bypass graft, that is a separate code. So we need to know, is the occlusion in a native artery, in a bypass graft, or is it in both? And if it's in both, then we are going to have a separate code. Now it goes on to remind us up to 2 coronary artery branches of the left anterior descending, left circumflex, and right coronary arteries are recognized. The left main and ramus intermedius coronary arteries do not have recognized branches for reporting purposes. So again, the branches are the separations from the artery separating out into 2 more arteries. So again, like the branches of a tree. All PCIs performed in any segment of a coronary artery branch is reported with 1 code. PCIs reported for up to 2 branches of a major coronary artery. Additionally, PCI third branch of the same coronary artery is not separately reportable. So again, we want to be careful what is and what is not reportable. For the coronary artery bypass grafts, the cabbages, each coronary artery bypass represents a coronary vessel. A sequential bypass graft with 1 or more distal anastomoses represents only 1 graft. Okay, so again, we need to know how many vessels are we going in, and are we going in the same vessel branch or not. If we're using the same vessel branch, as well as the vessel, 1 code. The second we start going into another vessel or a branch of another vessel, now we're going to need at least 2 codes. It goes on to tell us only 1 base code from this family may be reported for revascularization of major coronary arteries in its recognized branches. Only 1 base code should be reported for revascularization of a coronary artery bypass graft, its subtended coronary artery, and recognized branches of the subtended coronary artery. So yet again, we have 1 code that we're going to start with. So what is going to be the main procedure? The guidelines continue explaining the hierarchy. So the hierarchy, as we can see here, 99243, 99241, then 3324, 3728. So let's take a look at this. So 99243 or 92943. Percutaneous transluminal revascularization of chronic total occlusion, coronary artery branch, or coronary artery bypass graft. Any combination of intracoronary stent, arthrectomy, angioplasty, single vessel. 92941. Transluminal revascularization of acute total or subtotal occlusion, and then it goes on. So again, acute versus chronic. So again, they're describing what's going on. 92933, percutaneous transluminal coronary arthrectomy with intracoronary stent and angioplasty when performed. So again, we need to know what we're doing, what is the main reason we're going in, and then we have indented codes for each additional coronary artery or coronary artery branch. Okay, so we want to be careful. We also have some add-on codes to describe some of these each additional as well. So again, from the lowest service to the highest service. So it's going by how many things are they doing once they get into the coronary arteries. So the more intensive the service, the more intensive the code descriptor is going to be. Now again, it goes on to describe what happens when we have a bifurcation. So again, when the lesion is in 2 different arteries. So otherwise than keeping in mind things like the bifurcation, again, we have different reasons. Sometimes the code itself will say for acute myocardial infarction. So remember, the diagnosis can be wrapped into why we do the procedure and can be inside of the procedure description. As it goes down, it continues to go through what we're looking for. And then again, we get to the codes themselves. So again, these are our PTCAs, percutaneous transluminal coronary angioplasties. And so again, we also have arthrectomies. And again, you can see this is an arthrectomy with an angioplasty. So again, we're building. We're going from just an angioplasty to an angioplasty and an arthrectomy. And then we're going to an intracoronary stent with an angioplasty. So again, we're building upon. This is what they mean by that base code. Okay, so we always want to make sure that we understand what we're doing so we find the correct base code. Now, under the cardiography, The cardiography, again, these are going to be our ECGs, but this is also going to be the cardiovascular stress tests. So the first thing it tells us is codes 93040 to 93042 are appropriate when an order for the test is triggered by an event. The rhythm strip is used to help diagnose the presence or absence of arrhythmia, and a report is generated. So again, a lot of times the event is things like heart palpitations, or again, myocardial infarction, or not feeling well. There can be so many different reasons why we're doing that, try to find the arrhythmia. Now, there must be a specific order for an electrocardiogram or rhythm strip, followed by a separate signed, written, and retrievable report. It is not appropriate to use these codes for review of telemetry monitoring strips taken from a monitoring system. The need for an electrocardiogram or rhythm strip should be supported by documentation in the medical record. So if someone's in the emergency room, observation, or hospital, they're almost always hooked up to telemetry. Telemetry is that readout that comes talking about the heart's movement, okay? So this is something completely separate, and there has to be a documented reason, and there also has to be a report to go with it to be able to code for those services. Now, again, most of the time we are going to be coding 93000. Most common in the office, the medical assistant or nurse, possibly the doctor, will take the electrocardiogram, and then the doctor will read and write the report. But again, we can do the tracing only, and then we can do just the interpretation only. So for instance, some areas have facilities where you can just go get an EKG done. Well, whoever's doing the EKG is the technician, so they are doing the the tracing, and then a separate doctor is going to do the interpretation and report. Then we get to the cardiovascular stress tests. Okay, this is the treadmill and bicycle. So this is when they put the person on a treadmill or a bicycle, and as the person continues to go as fast as they can, they make it more difficult. So when it comes to the treadmill gets faster and the incline gets steeper. Same thing they can do similar with the bike. It gets more difficult and it simulates you going up a hill. And the idea is, again, they want to see how fast you can get your heart to pump to see if they can find what possibly could be the issue. So again, the most common is 93015. That includes everything. But then we have the supervision only and then the interpretation report only. But I want you to see this is echocardiographic monitoring and or pharmacological stress. So if someone can't get on a treadmill or a bike, or they're not able to complete the full exam on a treadmill or a bike, that's when they're going to do a nuclear medicine cardiovascular stress test. And that is when this code 93015 is going to be connected to the nuclear medicine stress test, okay? Because again, in that case, we are giving the patient the pharmacological stress and then running them through a machine instead of having them stress their body out naturally. So again, we're going to have to pair that code with a nuclear medicine code. Now, when it comes to the actual cardiovascular monitoring services, we have to remember, in cardiac surgery, we're going to have implantations of pacemakers, implantable cardioverter defibrillators, patient-activated event monitors, but we also have external monitors that patients can do for 24 hours, 48, 72, or even longer. We also have implantable ones, again, the patient-activated event recorder, which is implantable, which can go on for 90 days, 120 days. So what these codes are is this is to look at the actual device itself. Okay, so this is when we're checking the recording, we are doing an analysis with the report, we're doing an interpretation of all that information. So this is after it's been implanted, now this is checking in on the device and what it's doing for the patient. So as we go through, there's going to be a lot of definitions. I am not going to read through the definitions. So what you should be doing is making sure you are reading through all the definitions and you know what these are. And if you don't know what they look like, that's when you should go to your favorite search engine search for pictures. Search for a picture of a patient-activated event recorder, or the cardiac telemetry monitors, so you can see what they look like, so you understand what we're doing. So it starts out telling us that cardiovascular monitoring services are diagnostic medical procedures using in-person and remote technology to access cardiovascular rhythm data. Okay, Holter monitors include up to 48 hours of continuous recording. So that is something that's put on in a doctor's office. Patient goes home for a day or two, comes back. Mobile cardiac telemetry monitors have the capability of transmitting, tracing at any time, and always have internal ECG analysis algorithms designed to detect major arrhythmias and transmit to attended surveillance centers. So a lot of times you will see the reports of these coming through. So what these are is they are monitors where it has a Bluetooth or Wi-Fi technology in it. So after the person has a cardiac event, that information, sometimes while they're having the event, is being sent to the monitoring center, which then can send it on to the doctor. Now, event monitors 93268 to 93272 record segments of ECGs with recording initiated triggered either by patient activation or by internal automatic pre-programmed detection algorithm, or both, and transmitted the record of the electrocardiographic data when requested, but cannot transmit immediately based on the patient or algorithmic activation rhythm and require attended surveillance. Okay, so this again is going to require someone to be there. So again, attended surveillance, meaning that there is a technician somewhere. Okay, now I'm going to let you go through and read through all of these on your own, the differences between the different elements and the different pieces of equipment. The biggest thing is, what are we doing? So again, are we doing external electrocardiographic recordings? And again, then what are we doing? Are we doing all of it? So we're giving it to the patient, we are doing the analysis, we're doing the report, we're doing the interpretation, or are we just doing the recording or the analysis with report? Again, what are we doing? Are we doing a single average electrocardiography? What specifically are we doing for these patients? So that's what we need to know. What type of device are we dealing with? Then we get to the implantable and wearable cardiac device evaluations. Again, the biggest thing here starts on the top of the next page is time frames. Okay, so again, we have to be careful because certain devices have certain time frames. So this is why we always link back to the guidelines to let us know. So codes 9326061 and 93279 to 93292 are reported per procedure. Codes 93293, 9495, and 96 are reported no more than once every 90 days. Again, time frames. Do not report 93293, 4, 5, or 6 if the monitoring period is less than 30 days. So again, they're telling us as long as we hit 30 days, we can use these codes, and they go up to 90 days. Codes 93297 and 93298 are reported no more than once every 30 days. And do not report 93297 to 93299 if the monitoring period is less than 10 days. So again, always come back to your time frames when it comes to these devices, because these devices have very specific time frames when we can and cannot code them out. Now again, the biggest thing that we need to keep in mind is that for these codes, a lot of times we are doing, again, the in-person interrogation device evaluation. Okay, so this means that what we're doing, so otherwise in time frames, other things we need to keep in mind is who can code for these. So they tell us that, again, the same individual may not report an in-person and remote interrogation of the same device during the same period. So again, it's an either or. Either we're getting information remotely from the device itself, or we're having the patient come in. The other thing we need to keep in mind, it tells us a period is established by the initiation of remote monitoring or the 91st day of a pacemaker or implantable defibrillator monitoring, or the 31st day of an implantable loop recorder or implantable cardiovascular monitor, and extends for a subsequent 90 or 30 days respectively for which remote monitoring is occurring. So again, they're telling us pacemakers and ICDs are going to start on the 91st day and go for another 90 days. The implantable loop recorders and implantable cardiovascular monitors start on the 31st day after implantation and go for an extra 30 days. So again, we want to kind of keep in mind what is included. Now, a lot of times, again, there's a lot of do not reports. So keep in mind, we have do not reports in the guidelines themselves. We also have do not reports underneath the codes themselves. So again, pay attention to your notations as well as your guidelines. Okay, now again, it tells us the pacemaker and implantable defibrillator interrogation device evaluations, peri-procedural device evaluations, and programming device evaluations may not be reported in conjunction with pacemaker or implantable defibrillator device and/or lead insertion or revision services by the same individual. So when someone gets an insertion of one of these devices, a revision of these devices, that the evaluation is included in the surgical code. So keep that in mind. Okay, now we're going to get some more definitions. So again, attended surveillance, someone is physically there. Okay, again, this is just a copy from the pacemaker guidelines from cardiovascular surgery, single, dual, and multiple lead. Again, they go into the difference between electrocardiographic rhythm-derived elements, the differences between the implantable cardiovascular monitor, and again, you can read through these on your own. The implantable defibrillators, remember we have an ICD and an SICD. Again, this is all coming from surgery as well. The implantable loop recorder, so again, the differences between the implantable loop recorder, the interrogation device evaluation. So again, all of this information is here. So you should read through this on your own and make sure that you understand what this equipment does. And as I said earlier, you want to make sure that you understand not only what it does, but if you're not getting exactly what it should look like or what it does, definitely search for a picture. There are pictures of all of these devices online. That is a nice, easy way for you to understand what they do. Again, it goes into the differences between the pacemaker, the implantable defibrillator, cardiovascular monitor. Again, you know, these are the components of what they do. It then goes on to talk about the interrogation device and what these can do from remote interrogation devices. It then goes into the peri-procedural device evaluation and programming. So again, what do we do when we are doing an implantation or a revision? Again, what are the physiologic cardiovascular data elements that the doctor's getting? The in-person device evaluation, again, is physically seeing somebody. Now, this is what's important. So this right here is on page 635, okay? And it tells us the programming device evaluation includes all components of the interrogation device evaluation remotely or the interrogation device evaluation in person. And it includes the selection of patient-specific program parameters depending on the type of the device. So again, they're letting us know that the programming includes the evaluation as well as it to be specific depending on the device and the patient. Again, here are all of the components for a pacemaker, implantable defibrillator, implantable loop recorder, the transtelephonic rhythm strip. So again, what does each of these do? And you can see the codes here. Again, it says programming device evaluation. This says in person. This is a single lead. Indented code is a dual lead. Here's the do not reports. Again, lots of do not reports, so be on the lookout for those. So again, what type of system are we dealing with? Okay, are we dealing with an implantable loop recorder? Are we dealing with an implantable cardiovascular monitoring system? So what type of device are we dealing with? And then what are we doing to that device is what we need to know to properly code for this section. But again, so starting on pages 633 and going on to pages 635, you should really make sure you read through all of those different definitions so that you understand what's included in all of these codes. Okay, the next section is echocardiography. And this is why I was saying that in general, what we see here are not radiology, with the exception of some of the cardiac and cardiovascular procedures. So this is where we start seeing some of our ultrasounds in this section. So the echocardiographies here, these are ultrasounds of the heart itself. And so, again, what we're doing here is we're obtaining ultrasonic signals from the heart and great vessels. So this is going to include the aorta and the vena cava with real-time images and or Doppler ultrasonic signal documentation with interpretation and report. Okay, so usually the whole shebang is done. But when just the interpretation is performed separately, use modifier 26. So again, like we were talking about earlier, sometimes there's going to be a facility where the patient can go in and get the echocardiogram done, and then a technician, an ultrasound technician, does the echocardiogram, and then at a later date or a different doctor comes in and actually reads and writes the report. That's when we would use just modifier 26. If all of it's happening in the same facility, no modifier 26. We also have what we call a complete transthoracic echocardiogram without spectral or color Doppler flow, 93307. This is a comprehensive procedure that includes two-dimensional and, when performed, selected M-mode examination of the left and right atria, left and right ventricles, the aortic, mitral, and tricuspid valves, and the pericardium and the adjacent portions of the aorta. So again, that's what's included in that code 93307. Multiple views are required to obtain complete functional and anatomic evaluation, and appropriate measurements are obtained and recorded. Okay, so again, for this one, this is a transthoracic. So again, we're going through the thoracic cavity and we're going to get different angles of the heart. So they're going to be moving the ultrasound probe around so they can get multiple views. Okay, now, despite significant effort, identification and measurement of some structures may not always be possible. In such instances, the reason that an element could not be visualized must be documented. So just like in regular radiology, if we can't see something, it must be documented why we can't see it. Additional structures that may be visualized include the pulmonary veins, pulmonary artery, pulmonic valve, and inferior vena cava would be included as part of this service. So these are all the different parts of the heart and great vessels that are included. Okay. Now, they go on to tell us that a complete transthoracic echocardiogram with spectral and color flow Doppler 93306 is a comprehensive procedure that includes spectral Doppler and color flow Doppler in addition to the two-dimensional and selected M-mode examinations when performed. Spectral Doppler and color flow Doppler provide information regarding intracardiac blood flow and hemodynamics. So again, they're giving us what is included. So this is what we're looking for in the documentation from both the technician and the physician. So not only what type of test are we doing, but how are we doing it? Are we using M-mode? Are we using spectral Doppler? Are we using color flow Doppler? And again, they have to tell us what they're using so that we know what code to assign. And it's going to be very dependent on the patient's condition on what they're going to look for. And also, if the technician sees something abnormal, then they may do something slightly different as well. Now, it goes up to tell us that a follow-up or limited echocardiographic study, 93308, is an examination that does not evaluate or document or attempt to evaluate all the structures that compromise the limited echocardiographic exam. This is typically limited to or performed in follow-up of a focused clinical concern. So again, 93308 is basically like a quick look. We're coming in and looking at something specific. So we might be looking at just the right atrium or just the inferior vena cava. So we want to keep that in mind. So again, are we doing a full examination or are we doing a limited examination? Just like our other codes from radiology, we have complete and limited exams for cardiac ultrasounds as well. Now, other things that we might see here. In stress echocardiography, echocardiographic images are recorded from multiple cardiac windows before, after, and in some protocols during stress. So we were talking about this earlier. The stress is achieved by either walking on a treadmill, using a bicycle, or the administration of a pharmacologic agent that stimulates exercise or alters coronary flow. So again, if a patient cannot walk on a treadmill or use a bike or if they can't do it for long enough, then they're going to do the pharmacological stress. Now, it goes on to tell us the patient's ECG, heart rate, and blood pressure are monitored at baseline through the procedure and during recovery. So what this means is do not code for an ECG, okay? This is included as part of the larger procedure. Now, it goes on to tell us reports are prepared to evaluate during the duration of stress, the reason for stopping, the hemodynamic response to stress, the echocardiographic response to stress, and the echocardiograph response to stress. So again, what are we looking for? We're looking for how long the stress went on, why we had to stop, what happened afterwards. Now, again, we have to be careful because it tells us when a stress echocardiogram is performed with a complete cardiovascular stress test, use 93351. So again, we have larger codes to describe larger tests, okay? And again, they're telling us that when only the professional components of the complete stress test are provided by the same physician, use 93351 with modifier 26. Because again, it's going to depend on the facility. Sometimes the cardiologist is going to do the test, and sometimes they're going to have a technician. And so it depends. And so again, you need to know who is doing what in your facility. Now it goes on to describe, so this again is now on page 638. Again, sometimes we might not be able to see certain things. So when a left ventricular endocardial border cannot be adequately identified by standard echocardiographic imaging, echocardiographic contrast may be infused intravenously both at rest and with stress to achieve that purpose. Code 93352 is used to report the administration of echocardiographic contrast agent in conjunction with the stress echocardiography codes, which are 93350 and 93351. Supply of the contrast agent or drugs used for pharmacological stress is reported separately in addition to the procedure code. So again, remember, if we're doing a procedure, usually the administration code and whatever is inside of that administration, whether it's in a needle or whether it's in an IV bag, must be coded separately. So if we are using pharmacologic stress, we are going to need a minimum of 3 codes. One to describe the administration of it, one to describe the drug that's inside of it, and one to describe the testing that we're doing. And remember, like we were talking about with vaccines in part 1, we always need to pair up an administration with a product, okay? In this case, the administration is the pharmacologic agent for stress. The product is what is inside of that agent. So what specifically are we coding for? Now, if you look on page 639 in your book, you're going to see a picture of code 93355. It's used to report a transesophageal echocardiogram, known as a TEE, during transcatheter intracardiac therapies. So what they do is they stick a small ultrasound probe down the patient's mouth, and what they're doing is getting a picture from the back side of the heart. So the transthoracic can look at the anterior portion and the lateral portions of the heart very well. So it can look at the front and the side. The back is much more difficult to see, and so this is one way to do it. So they tell us that codes 93355 is reported once per intervention and only by the individual who is not performing the interventional procedure. So again, remember, a lot of times we're doing interventional procedures, so this is a way of checking in. So again, be careful. Who is doing this? Can we code for it? Code 93355 includes the work of passing the endoscopic ultrasound transducer through the mouth and into the esophagus when performed by the individual performing the TEE, Diagnostic Transesophageal Echocardiography, and ongoing manipulation of the transducer to guide sizing and/or placement of implants, determine the adequacy of intervention, and assessment for potential complications. So again, they could be placing something, they could be looking to try to diagnose, or they could be looking for complications. And again, these are real-time images. So again, the final written report is always included. Remember, all radiology codes include the written report. It's part of the code. Now, what we have to worry about is the differences between the congenital cardiac anomalies and all the other ones. So for instance, if you look at code 93303, it says transthoracic echocardiography for congenital cardiac anomalies. Okay, so again, we have to be careful. If we're looking at 93307, it's just echocardiography, transthoracic, real-time image, etc. So we do have codes in this section for congenital cardiac anomalies. So we need to be careful. As we go forward, we're going to see codes here and there that say specifically for congenital cardiac anomalies. So if someone was born with a congenital anomaly, then we want to use those codes versus the other codes. So again, knowing the patient's history is very important. This is why the diagnoses can really affect the procedures in the real world. Now we get to cardiac catheterization. So now what we're doing here is we are going in, and again, you can see pictures of this on page 641. We like to go into the brachial vein in the arm or the femoral vein in the leg. And what we're doing is we place a catheter in. And then inside that catheter, we can put in instrumentation, and we can also put in different mechanisms to be able to take out blood and check, different aspects of what's going on inside the cardiac system. So they tell us, cardiac catheterization is a diagnostic medical procedure which includes introduction, positioning, and repositioning when necessary of catheters within the vascular system, recording of intracardiac or intravascular pressures, and final evaluation and report. There are two code families for cardiac catheterizations, one for congenital heart disease and one for all other conditions. Okay, so again, keep that in mind. Anomalous coronary arteries, patent foramen ovales, mitral valve prolapse, and bicuspid aortic valves are to be reported with codes 93451 to 93464 and 93566 to 93568. So again, they're just letting us know where to go for these specific conditions. Now, it's going to go through the differences between the right and the left. And so the big thing here, again, is what is included. We have a right heart catheterization, we have a left heart catheterization, we have a combined right and left heart catheterization, and then while we're already in there, we can do other testing. So again, what's included? Let's see. A right heart catheterization includes the catheter placement in one or more right-sided cardiac chambers or structures, like the right atrium, right ventricle, pulmonary artery, or pulmonary wedge, obtaining blood samples for measurements of blood gases, and cardiac output measurements, FIC or other methods when performed. Okay. So again, we're going to the right side of the heart. We're looking at what's going on the right side of the heart, and we are looking at the blood gases and cardiac outputs. So the blood flow through the right side of the heart. A left heart catheterization involves catheter placement in the left-sided cardiac chambers, the left ventricle or left atrium, includes left ventricular injections when performed. So again, this time we're going into the left chambers of the heart as well. Now, it goes on to tell us, do not report 93503 in conjunction with other diagnostic catheterization codes, okay? When right heart catheterization is performed in conjunction with other cardiac catheterization services, report 93453, 56, 57, 60, and 61. So again, it's letting us know that we have a variety of these procedures. We can just be going in for more of a diagnostic catheterization where we're going in looking around and seeing what's going on, or we can go into a catheterization and then do more procedures. So it goes on to tell us, for placement of flow of a directed catheter like Swan's Gantz performed for hemodynamic monitoring purposes, not in conjunction with other catheterization services, use 93503. So again, what are they using? So in this case, instead of it being a technique, it's a piece of equipment that we may have to be on the lookout for to get the correct code. Now, this is what's interesting. Right heart catheterization does not include right ventricular or right atrial angiography. That is a separate code. Same thing. When a left heart catheterization is performed using either transapical puncture of the left ventricle or transeptal puncture of the intact septum, report 93462 in conjunction with 93452, 53, 58 to 61, 93653, or 93654. So again, basically they're reminding us that what they've already put in the upper part of the paragraph is only what's included. If we're doing more, it's going to be another code or an extra code. Okay. Now it goes on to tell us the cardiac catheterization codes 93452 to 93451, other than those for congenital heart disease, include the contrast injections, imaging, supervision, interpretation, and report for image typically performed. Codes for the left heart catheterization 93452, 53, and 58 to 61, other than those for congenital heart disease, include intraprocedural injections for left ventricular and left atrial angiography imaging and interpretation when performed. So again, this is also what's included in these procedures. And again, they're reminding us that we have separate ones for congenital heart diseases. So we have to make sure if it's for a congenital heart disease that we are getting it correctly. Goes on to tell us cardiac catheterizations 93451 to 93461 include all road mapping angiography in order to place the catheters, including any injections and imaging, supervision, interpretation, and report. It does not include the contrast injection and mapping, imaging, supervision, and interpretations, and report for imaging that is separately identifiable by specific procedure code. So again, it includes placing the catheters and injections, but it does not include what's inside of that injection. Okay, so then again, we're going to have to use a code from HCPCS to make sure we get paid for that. Now, they also tell us when cardiac catheterization is combined with a pharmacologic agent administration with specific purposes of repeating hemodynamic measurements to evaluate hemodynamic response, use 93463 in conjunction with 93451 to 93453 and 93456 to 93461. Okay, so basically this is giving the patient a drug to see if giving that patient a drug changes the flow of the heart, of the blood through the heart and through the great vessels. Okay, so again, they're telling us that, again, we have a separate code we use in conjunction with these catheterization codes to describe the pharmacologic agent administration. They also tell us that when cardiac catheterization is combined with exercise, so walking or arm or leg ergometry protocol with specific purposes of repeating hemodynamic measurements. Again, it goes on, sorry, it got cut off. To evaluate hemodynamic response, use 93463 in conjunction with these codes. So again, it's just giving us more information. So right here, here's our right heart catheterization. Again, we do not report with these codes. You can see right here, here's the catheter going in. The left heart catheterization. Again, we can go into the femoral vein, right or left side. They just happen to be both showing the right. This is the combined right and left heart catheterization. And then as we're going to see in a minute or two, we have a table that can also help us out with all of these. So again, injections, we have to be careful because we have the administration and we have the agent. So all injection codes include radiological supervision, interpretation, and report. Cardiac catheterization codes other than those for congenital heart disease include the contrast injections for imaging typically performed during those procedures. But again, if it's above and beyond, then we're going to have to code for these. Now, this is starting on page 644. It goes on for a few pages, and this is a great table because what it really does is it shows you what codes can be used together. So you'll notice that we cannot use 93451 with 93452. Why? Because there's not an X here. So what we would do is we would use 93453 because 93453 uses both of them. And then you can see what add-on procedures can be used, and when can we add in a coronary artery replacement or a bypass graft if the patient has that. So this is absolutely great. And if this is one of the areas of medicine you're going to be working in, this is definitely a table that you might just want to photocopy so that you have it easily available to you. It's a great table, and it also can be very, very helpful when you're sitting for your credentialing exam, because a lot of times they will give you more difficult questions, especially in medicine. And so they might give you one of these. And so again, you can come to the table and you can say, okay, I'm pretty sure it's code 93453, but can code 93462 go with it? And then you can go across and say, yes, these codes can be paired together. So biggest thing here, number one, what are we doing? Are we going into the right heart? Are we going into left heart? Are we going into both of them? Are we doing anything else otherwise than looking around and taking samples while we're there? Because if we are, that's going to be an additional code. But also be careful, because the congenital cardiac anomalies are in a separate section. They come after these codes, okay? And we use those for anyone born with cardiac anomalies. All right, so now we're looking at our repair of structural heart defects. And again, a lot of these are congenital. This is the bottom page 648. All right, so it's telling us codes 935, 90, 91, and 92 are used to report transcatheter closure of a perivalvular leak. Codes 93590 and 93591 include, when performed, percutaneous access, placing the access sheaths, advancing the delivery system to the perivalvular leak, positioning the closure device, repositioning the closure device as needed, and deploying the device. So again, getting there and being able to get to the exact area and opening, that's the deploying, the opening of the device is all inclusive here, okay? So it also tells us that codes 93590 and 91 include, when performed, fluoroscopy, angiography, radiological supervision, interpretation services performed to guide the PVL closure. So again, a lot of times fluoroscopy is going to be used. Why? Because it's one of the easiest. Again, that's the patient on the table, x-ray equipment above them, live feed. Because again, they can easily stick a wire, a guide wire, into the catheter so they can see exactly where they are, so they can make sure they're in the right part of the right vessel. Okay, so that is something that is included. The angiography is also going to help to make sure that we have closed these leaks, okay? Because if we're going in to close a leak in a valve, we want to make sure that leak has been completely fixed. So usually after we finish the closure of the leak, then we'll do an angiography to make sure that the flow is appropriate. They also tell us that codes 93590 includes transesophageal punctures and left heart catheterizations, which is also a left ventriculography. So code 93590 includes a lot of different aspects. So again, it includes all of these different types of codes when performed. So keep in mind what is included. And then the transapical left heart catheterization, 93462, may be reported separately when performed, because again, this is something that's not always performed with the left heart catheterization. It goes on to let us know, though, that code 93591 includes, when performed, supravalvular aortography, left heart catheterization, and left heart ventriculography. And yet again, the transapical left heart catheterization may be reported separately. So again, keep in mind what is included in these codes. Then guess what? The same guidelines that we see over and over and over again for the angiographies shows up again. So here's the thing. Again, keep in mind, the angiography is included in these codes. So the only time we can code for an angiography is if the patient fits into one of these scenarios. Again, there's no prior study. The prior study is available, but there is inadequate visualization, the patient's condition has changed, or there is a clinical change during the procedure. So again, we keep seeing the same guidelines over and over and over again for our arteriographies and our venographies. So again, we need to know more information, and this is why we always want to go back into the medical record first to see if this information is there, and then always query the physician. Ask the provider, has the patient had one of these before? Because again, if they haven't, then we can code separately for it. Remember, we always want to code for exactly what our doctor does. And if we can use an angiography code because the patient has never had an angiography before, then we want to do that because that means our doctor is doing extra work. Our provider is doing extra work for us, and so they should get paid for that. Now, I just want to point this out, even though I didn't highlight it. For our same session, same day diagnostic cardiac catheterization services, report the appropriate diagnostic cardiac catheterization append with modifier 59, indicating separate and distinct procedural service from a PVL closure. So again, if let's say we went in originally to do a right heart catheterization, and when we went to the right heart catheterization, we see a perivalvular leak. Then we go in and we fix that valve. Okay, what we have to do is put a 59 on the catheterization code saying it was separate and distinct. Okay, or we could be doing a PVL closure on the right heart, and then we could be doing a left heart catheterization, or vice versa. Okay, so again, the modifier 59 because it is a distinct service. All right. Then we get to some what we call intercardiac electrophysiological study. And so what we're doing here is we're doing recordings and we're doing pacings of the different parts of the heart. Okay, and so what we're doing is we're trying to figure out where the electrical signals are coming from and going. And these are usually done for people that are having issues specifically with signals being off. So these could be drop beats, these could be skipped beats. A lot of times this is fibrillation, when the heart just kind of goes into a flutter and it just kind of shakes instead of doing the lub-dub pumping. So intracardiac electrophysiological studies, or EPS, are invasive diagnostic medical procedures which include the insertion and repositioning of electrode catheters, recording of electrograms before, during, and after pacing, programmed stimulation of multiple locations of the heart, analysis of recorded information, and report of the procedures. In many circumstances, patients with arrhythmias, so again, these are bad rhythms, are evaluated and treated at the same encounter. In this situation, a diagnostic electrophysiological study is performed, induced tachycardia are mapped, and on the basis of the diagnostic and mapping, the information in the tissue is ablated. Okay, so let's talk about what they're doing here. So the first thing that they're doing is they're doing arrhythmia induction, okay? And so what they do is they want this person's heart to go into arrhythmia, to go into a bad rhythm. Because when the heart goes into a bad rhythm, they can then start to map why the heart is going into a bad rhythm and what part of the heart is not receiving the correct signal. So again, the biggest thing is in most electrophysiological studies, an attempt is made to induce arrhythmia from single or multiple sites within the heart. Arrhythmia induction may be achieved by multiple techniques, like by performing pacing at different rates, or programmed stimulation, introduction of critically timed electrical impulses. So again, they're sending electrical impulses to the heart on purpose to get the heart to start going into its arrhythmia, going into its bad rhythm. Now, because of arrhythmia induction occurs via the same catheter inserted for the electrophysiologic, electrophysiologic studies, the catheter insertion and temporary pacemaker codes are not additionally reported. So again, arrhythmia induction, we're going to try to figure out what the problem is. So they tell us that codes 93600 to 93603, 93610, 12, and 18 are used to describe unusual situations where there may be recording, pacing, or an attempt at arrhythmia induction from only one site in the heart. Codes 93619 describes only evaluation of the sinus node, atrioventricular node, in the His-Purkinje conduction system, without arrhythmia induction. So again, let's be careful. It's telling us what is and what is not. Goes on, codes 93620 to 24, 93640 to 42, 93653, 54, and 56 all include recording, pacing, and attempted arrhythmia induction from one or more sites in the heart. So again, is it one site or is it multiple sites? So the first thing we're going to do is we are going to try to find what the issue is. Then we are going to do the mapping. So again, the mapping is, again, when tachycardia is induced, the site of the tachycardia origination or its electrical path through the heart is often defined by mapping. Mapping creates a multidimensional depiction of tachycardia by recording multiple electrocardiograms obtained sequentially or simultaneously from multiple catheter sites in the heart. So again, the mapping is going to show us exactly where the problem is. So the induction is trying to get the heart out of rhythm so that we can then map, find the area that has the problem, and then we can ablate. Once the part of the heart involved with tachycardia is localized, the tachycardia may be treated by ablation, the delivery of radiofrequency or cryoenergy to selectively destroy cardiac tissue. Ablation procedures are performed at the same time as electrophysiology studies and therefore represents a combined code description. So again, biggest thing here is usually we're doing all at the same time. We're inducing, we're mapping, we're ablating, okay? Same session. Now there's one little part I want to show you guys down here. The differences in the techniques involved for ablation of supraventricular arrhythmias, ventricular arrhythmias, and atrial fibrillations are reflected within the code descriptions of 93653 to 93657. So again, when we're looking at these, we have to remember that it will tell us. So let's see, 93563 tells us that we are doing induction with right atrial pacing, right ventricular pacing, bundle of his recording, treatment of supraventricular tachycardia by ablation. So again, it tells us exactly where it is. So that's just a hint saying, look at the code descriptors. Remember, in general, whether you are in cardiac surgery, radiology, or medicine, always read through the full code descriptor, double check if you need an indented or add-on code, and always look at the notations to help you out. And again, it goes on to describe the other codes that we're going to see and where they fit with. And yet again, the biggest thing is right here, modifier 51 should not be appended to 93600, 93603, 93610, 12, 15 to 18, and 93631. And again, we have the no symbols in front of them, reminding us these are modifier 51 exempt. So again, we don't have a lot of those symbols, but when we see them, it means we get paid at 100% for each and every one of these. And the reason is, in this case, is because we have to do a recording of each and every one to figure out where the problem is. All right. So we'll go through a couple more sections and then we'll break it out and we will end up doing a third section of medicine as well. I just want to talk a little bit about peripheral arterial disease rehabilitation. There's only one code, okay? So again, this is pretty simple, but there are guidelines that remind us how to code it. So PAD, rehabilitative physical exercise, consists of a series of sessions lasting 45 to 60 minutes per session, involving use of either a motorized treadmill or a track to permit each patient to achieve symptom-limited claudication. Each session is supervised by an exercise physiologist or a nurse. And so again, these are people that have issues with their legs. And so again, what they're doing is they are doing certain exercises to help get that blood flow into their legs and learn to recognize when they might need to get up and do some walking because they start feeling discomfort in that area. Again, one code, but it's important to know that. We're going to stop here. We're going to pick up with non-invasive physiological studies in medicine part 3.